The rules of engagement, clinical algorithms in psychiatric medication, the hierarchy of treatment. In the vast majority of psychiatric cases, once a condition crosses the threshold from moderate into severe, medication becomes the most effective treatment available. We categorize these treatments into two distinct clinical scenarios. New treatment, for a patient who has never been treated or has been off medication for over 1 year. Continuing treatment, for a patient currently on a regimen. This includes patients in remission, maintenance, or those with residual symptoms that the patient finds unacceptable. The diagnosis first, protocol treatment, must strictly match the diagnosis. We follow a specific hierarchy of evidence to remain both ethical and scientific. First choice, FDA-approved medications for the specific diagnosis. Second choice, off-label medications, legitimate indications supported by randomized, double-blind, placebo-controlled studies. Third choice, indications supported by lesser evidence, open-label, cohort, or case reports, only after all higher-tier options are exhausted. The 5 gears of medication change. In psychiatry, there are only 5 possible moves when adjusting a regimen. We do not guess. We follow a rational strategy based on the patient's response. Increase, the most rational strategy for persisting symptoms. It has the lowest risk of making things worse. It will either help or do nothing. Decrease, reserved almost exclusively for managing side effects in a patient who is otherwise benefiting. Add, used only when the current medication provides some benefit but is already at the maximum dose. Replace, the only rational option if a medication is at maximum dose and provides 0 positive effect. Change timing, used to mitigate side effects, for example, moving a sedating dose to the evening, and the time lag reality. How do we choose the specific drug? Historical success. If a drug and dose worked in the past, we return to it. Strategic side effects. If no history exists, we choose an FDA-approved drug whose side effects benefit the patient. For example, a sedating drug for an agitated patient. The expectation shift. We must break the classic medical model. Onset. Unlike an aspirin, psychiatric meds may show slight improvement in 2 to 3 days, but require 6 to 8 weeks for maximum effect. Duration. We do not stop when we feel better. Remission requires 6 to 12 months of continued treatment at minimum. For many, treatment is a multi-decade necessity for stability. Compliance through autonomy. Compliance is the #1 predictor of a positive outcome. To ensure buy-in, we follow a shared decision-making model, offer 2 to 3 options, present the pros, cons, and probabilities of side effects. Patient as appraiser. The patient is the only one who can decide if a therapeutic gain is worth a specific side effect nuisance. This reduces resentment and increases investment. Contingency planning. Establish what-if protocols. Mild. If nauseous, take with food. Emergency. If a rash develops on lamotrigine or fever/stiffness occurs on a neuroleptic, stop and go to the ER immediately.